As many of you know, in Health Coaching and Beyond, we alternate conversations between Tim and I, chewing over hot topics and latest news and emerging ideas, but also bringing you conversations with thought leaders and people we admire in the field of health coaching and beyond. This week, I'm joined by local Sheffield Director of Public Health, Greg Fell OBE. He's also president of the Association of Directors of Public Health, so he's a key national voice in the sphere of public health. With our Practitioner 2 level certificate being accredited as an Ofqual Level 3 qualification in health coaching by the Royal Society of Public Health, it felt really meaningful to talk public and population health with Greg and explore the balance between individual behaviour change alongside system level policy and the place of people's agency to influence both. We explore why obesity is the new tobacco. We explore commercial determinants of health. We talk about the fact that prevention's happening, perhaps going unnoticed, and we even get onto the place of workplace and lifestyle medicine. So lots to get you thinking as always, and we hope you enjoy the conversation hearing Greg's views. Hello, folks. Welcome back again. And I am absolutely delighted this week to be joined by Greg Fell, who is someone I've known for many years. He's the Director of Public Health here in Sheffield, a really crucial role, was absolutely seminal during COVID. And in fact, you're now Greg Fell OBE, aren't you, Greg? Yeah, which I think was on the result of a lot of the stuff you did during COVID and maybe a sign of your stature in the field. And of course, you're also now president of the Associate of Directors of Public Health. So you're quite a prominent figure, Greg. So it's great to have you on the podcast.
Cheers, Ollie. It's always a pleasure. Seminal was not a word I would use about myself, but there you go. Just Greg from Sheffield.
Yeah, from Sheffield and brilliant. And you have such a crucial role and I think what we want to dive straight into is that, you know, I know that as Director of Public Health, you're thinking about how a system can work that makes healthy choices easier, if you like. And we've often debated on whether that's a system thing, how the system operates, or whether it's down to the, personal individual roles that people take. And I think that's a really interesting place to start. I know you've written recently in your blogs about this book, It's On You. And I wondered if you just wanted to sort of start there and sort of talk about some of the things you think about as a result of reading that and some of the blogs recently.
Yeah, sure. So just a little bit of history then. So I kind of first came into the thing that one of the constituent parts of what we call public health, which was then called health promotion, in the early 90s. And when I did my first training in the space, we had this definition of health promotion is basically health education, which was largely around educating individuals so they behave, they eat less fatty foods and drink less and all that kind of stuff, and healthy public policy. And there was a whole bunch of psychological theory underpinning that. I'm old enough to remember the first iteration of the stages of change model. I don't know if that's still a thing. I assume it is.
Jasper Di Clemente, that's still there.
The health belief model, the health action model. There was a whole bunch of stuff. But we always neglected the healthy public policy bit because it's hard. It's hard to create an environment in which the healthy choice is the default choice. It requires more political agency. It requires political shifts quite often. Therefore, it's easier to default to individuals, and that's just what we do. So my starting point was then, but I guess I've never really left that. If you want to shift the behaviour of populations, if you want to shift the behaviour of individuals, work at individuals. If you want to shift the behaviour of populations, you've got to shift the system. So Indy Johar and others do a fairly regular system shift podcast, which I don't know if it's okay for one podcast to remember to recommend other podcasts, but System Shift is a really, really good podcast. If one of my jobs is around the prevention of non-communicable disease, cardiovascular disease, cancer, etc. That's bluntly why people are poorly and why people die. You got to quickly get into the business of, well, why is that? Lack of physical activity, or as I frequently colloquialize it, people don't sweat enough and lift heavy stuff. Smoking, alcohol, access to poorly nutritious food. So I can stand outside Tesco's handing out eat more carrots leaflets all I want, and I have done that in my past life. But it just doesn't make that much difference. It doesn't really shift the dial. So you get into sort of the iframe stuff, interventions oriented and focused at individuals one by one, and there's 572,000 of those individuals in Sheffield, or you get into S-frame stuff, shifting the system. So I guess I've always been in that space, but the thing that kind of crystallized or recrystallized it for me probably about 6 months ago was this book I read by Nick Charter, George Lowenstein, called It's on You. And I would say it's the best public policy book I've read in like a decade or more. And the TLDR was the sort of we've basically got the policy focus, the needle of policy focus has been on individuals and personal agency and personal responsibility for drinking responsibly and gambling responsibly, yada, da, da, da. And I'll come on to agency in a minute. It does matter. But that takes the shift of focus away from policy. And if you look at World Health Organization best buys to prevent non-communicable diseases, the interventions are price, marketing and advertising, and availability and access to good quality treatment. So in tobacco, it's smoking cessation. In alcohol, is alcohol addiction treatment. So you can apply that to pretty much anything. But policy has focused on individuals, and that's somewhat problematic. And the book, It's on You, basically describes how that applies to a whole bunch of areas that I would call public health and other people would call public policy. The difference is probably moot, but it also applies. The book talks about retirement savings and economic inequality and plastic pollution, and not necessarily a thing for this country, but gun violence is, a massive issue in the States, significant cause of death and illness or morbidity. And there's that sort of the whole guns don't kill people, people kill people. Well, that's the National Rifle Association's mantra. That keeps policy focused on irresponsible adults that haven't kept their guns in safe places, rather than the per capita gun ownership in the States. So It's on You talks about the psychology that underpins that public health policy, and it was a really, really, really interesting read. Probably not loads new to folk that work in my field, and kind of sets up that a focus of policy on agency, and the focus of individual agency, and a focus of policy on the structural conditions in which people live out their lives as in competition with each other, which there's a little bit of zero-sum game stuff in that. But actually it depends on what your focus is. If my jobs and my responsibilities focus is to help individuals, and many clinicians, that is their job, and they do a bloody good job, I may add too. But my job is the responsibility for setting the conditions in which we can enable health, which is a different job. So they are different things, and we should think about them differently rather than as indirect competition.
Well, that's a brilliant framing. And I think that's why I'm so interested in this conversation, because I think with you coming at it from a population point of view, and I guess myself being a GP and teaching people to use health coaching skills, mostly on a one-to-one level, but increasingly on a sort of one-to-many and maybe a system level, it's fascinating to explore the interplay, because it's tempting sometimes to get very polarized and think, well, it's all about the system. Doesn't matter what anybody does, because it makes no difference if the kind of policy and the environment isn't right. And equally, then you can kind of get the other way, can't you? And sort of say, well, you can make the environment right, but if people don't take responsibility for themselves, and there is a difference between how people respond in the same situation, it doesn't matter. And you get people forming two camps. And I get the impression, Greg, you like to look at the middle ground as well as the broad picture. I'm
probably in the broad picture camp. If I had to be in a camp, I'd be in the broad picture camp, because that's my job. That's the responsibility that I've got. But I fully recognise there are a number of camps, and none of them are invalid camps, and people can happily camp in either of the two, three, or maybe even more camps, as far as I know.
A lot of camping,
but there's a lot of camping going on. But say, pick obesity. Obesity is nearly the new tobacco. Everyone says X is the new tobacco. Tobacco is still broadly the new tobacco, but as smoking prevalence comes down, I'll come on to that. Obesity, bluntly, we're not doing very well around obesity. Obesity causes cancer, causes cardiovascular disease that you as a GP will know all too much about, and causes early death and early illness. And that's a thing. So obesity is nearly the new tobacco as smoking prevalence comes down. Weight management interventions, personal responsibility in that space does matter. But largely is outgunned by the environment in which we live our lives. People will say there's a sort of the mass loss of personal responsibility, and that's why the prevalence of obesity shot up in our lifetimes. The prevalence of obesity shot up. Yeah, when I was a kid and you were a kid, I'm figuring you're about the same age as me, about 24.
Yeah, I think we're roughly the same age.
Early 20s. Like obesity wasn't really a thing, but it genuinely is a thing now, and that is causing illness. And one of the reasons why the long-term fall in cardiovascular mortality is leveling out is obesity is now playing into diabetes, which is playing into cardiovascular outcomes. So obesity is definitely a thing now. We haven't had a mass loss of personal responsibility in that time. What's fundamentally shifted is the food environment. So we can have all the agency we want, and agency matters. Let's not pretend that agency doesn't matter, and acting responsibly and doing the right thing. Of course it matters, but it's outgunned by the environment, and that's kind of where I am in my thinking in that space.
No, I get that.
And if the advertising environment is saturated by, I'll be pejorative here, but turkey Twizzlers and McCain oven chips and other brands are available, I hasten to add. And then guess what? That drives consumption, that drives population consumption of calories, which drives obesity. So, you've got to help individuals, and individuals have to do the right thing. But one of my responsibilities is to try and set the environmental context as straight as is possible. But I know full well I'm up against exceptionally powerful multinational corporations, which makes my job hard and interesting at the same time.
Yes, absolutely. And we're very grateful for what you do in fighting to help the environment work better, because behaviour change works better, doesn't it, if the environment is more favourable. But let me be a bit provocative then, actually. You talked about smoking, the ground we've made on smoking. Do you think the food industry has become like the new kind of tobacco industry?
Well, it's well documented in my trade. We call this space is called increasingly the commercial determinants of health. Our health isn't determined by the individual or aggregate of our choices. It's determined by the choices made by multinational corporations, usually headquartered in Geneva or Bern or somewhere of that ilk. And we know full well that those corporations, is well documented and well evidenced that those corporations share exactly the same playbook in terms of their influencing and lobbying tactics on governments, the way in which they frame obesity as a matter of personal choice. That environment, that context, and that narrative and discourse upon which policy is set is very, very well shaped and sculpted by PR and advertising, which sets and shapes norms in which our policymakers form their views and opinions and eventually their policy choices. All of that is very, very well documented. In my trade, it's known as the playbook. The tobacco industry largely invented the playbook, but now it was put on turbocharged doses of steroids by the oil industry to sell as fossil fuels and all things that fall in that ship. And of note, climate is a significant public health hazard. And now it's well documented that many of what I would call health harming industries use broadly the same methods and tactics to maximize their profits. I would, were it me. I'm responsible. If I'm in charge of Mondelez or Kraft Foods or whatever, and again, other food brands are available. My responsibility is to my shareholders to maximize profit. That comes from maximizing sales. So of course that's the way it works, but the consequence is obesity and all of the early death and illness that comes from that. So, but the playbook space is well trod.
I mean, I'm trying to sort of make sure we get some good positives out of this in terms of, so I know you've told me a lot in the past about how positive the stories around tobacco in a way, and as a clinician, I'm often used to sort of like, inducing sort of smoking cessation programs, having brief interventions and operate on a personal level, but there's also been some wide system change as well, some policy levels. So would you put that as a success of both things working in parallel?
Stellar success. And there are a fair few successes, and I'll call it public health. I accept other people will call it different things.
Go on. Share more. I'd like to hear.
But CDC published a top success stories of the last 100 years on their website. I presume it's still up there. I don't know. I've not checked recently. But the long-term story on the near eradication of measles by basically vaccinating anything that moves was clearly a public health success story. Tobacco control is clearly a public health success story, and there were 10 others. I forget what they all are. Long-term reduction in motor vehicle collisions, killed and seriously injured on the road. Ditto. It's a systematically applying the right interventions doggedly and well over a long period of time. That's what change looks like. So when I came to Sheffield a decade and a little bit ago, smoking prevalence was, from memory, about 19%, 19. Now it's about 12%, a little bit more, a little bit less, depending on how you do the prevalence surveys. That didn't happen by magic. It happened because people doggedly worked at it over a long period of time. Clinicians up and down the city have done brief interventions and made referrals to definitive stop smoking services over a long period of time. That in itself probably reduces prevalence by somewhere around 0.15 to 0.25, a quarter of a percentage point a year. Not much, but if you aggregate that over quite a few years, it adds up. At the same time, both locally, we've done a lot on policies, working with schools on smoke-free environments, working with universities, hospitals, and other big public service environments on smoke-free environments. That's shifted norms. And one of the early things that we did in my time here was implement smoke-free playgrounds. So that kids wouldn't see their parents smoking in a playground, because that shapes kids' norms, and that the norms influence their ongoing behaviour. We've done a lot on investing in trading standards teams to basically confiscate illegal and illicit tobacco that was on sale in shops across the city in ones and twos at really, really cheap prices. Well, guess what? That's why 5 kids a day start smoking. So we basically used smart investment in trading standards to kick doors down and confiscate large quantities of illegal tobacco and now illegal vapes. Of note, which is often linked to organised crime, which is clearly, a very important side benefit. And then nationally, relentless pressure on price, relentless pressure on advertising, marketing. So the collective effort of all of that has shifted smoking prevalence from, as I say, sort of 17, 18, maybe 19% down to about 11, 12%. No one, you can't see the benefit of that, because it's like the success in prevention is bad stuff doesn't happen. Well, you can't count that because it doesn't happen. But countless people who may otherwise have had a diagnosis of lung cancer or had a stroke or whatever as a consequence of smoking will not have that. So that's kind of a good thing. So that's a success. Sadly, as I say, we're not doing quite so well in obesity, and ditto, we're not doing quite so well in alcohol. But policy makes a difference is the broad story, and broadly we know what to do. And it's a collective of one-to-one interventions for those who are responsible for one-to-one interventions, and system shift type of interventions for those who are responsible for that. Collectively, that's the thing that makes the difference.
That's brilliant. And I pick up on, I'd love to come back to prevention a bit later on, but maybe, you've said that kind of obesity is almost like where smoking was, and we've learned a lot from smoking of that combined effort. So if you were looking at how we go forward with obesity, obviously we've got these GLP-1 drugs, which are being prescribed on mass or being used kind of privately on mass levels. We've got some one-to-one behaviour change interventions, and maybe there's a big space for policy changes as well. How would you see the ideal world playing out then to tackle the obesity crisis in a joint way?
So on national level, there's something around getting the right ecosystem and underpinning discourse and narrative to enable shift of policy away from things that only focus on individuals towards structural system shift in the food system, particularly the food system. I'll come on to physical activity in a minute. So in terms of the specific policy bucket list, has been well described by lots of people. Most recently, Nesta, who were quite active in this space, who are a national think tank, have written, this is our policy bucket list to halve obesity in 20 or 30 year time horizon, I think. And let's be clear, it will take that kind of time horizon to do that. So I often point people towards Nesta, and I think Nestor have perhaps overplayed the importance of GLP-1 agonists a little bit in that, but broadly, I think Nestor have done a decent job. There's something around the food environment in particular, and I frequently come back to Henry Dimbleby's food strategy, which was published, sort of an independent commission for the previous government, was published 3 or 4 years ago. It was brilliant. It was absolutely brilliant. It didn't get implemented as incepted and intended, but we may come back to that. But sort of broadly at national level, I'm in that kind of space. And then at local level, it's the sort of I'm well documented as being pretty pushy about, are we giving planning permission to new fast food hot food takeaways within certain perimeters of schools, and the council now has a planning policy that's currently going through the inspection process. It may come out of that, but that policy has been used to say no to hot food takeaways. We need to be in the space of school food, which matters. We need to be in the space of ensuring there is access to sustainable and nutritious food, which is partly a sort of a national food system, partly a local food system. For me, most of that comes together in the city does have a food strategy, and most of the food strategy bits that I'm cited on are largely focused on access to sustainable and nutritious food, and some of that is about price, some of that is about availability, which is a sort of a food system thing. Of note, the council has a policy on advertising and sponsorship. We will really come into effect when we novate the commercial contracts for the JC Deco and Clear Channel billboards and the like. But we're basically trying to out Sadiq, the mayor of London, who said no junk food ads on our transport estate. Well, we've said on any estate that the council owns. What I can't do is if one of the 2 football clubs take a sponsorship. It's not my responsibility, but we're trying to set the right norms in the right context in that space, and be really, really pushy, and certainly be pushy on food that is supplied by the public pound should be nutritious, and sometimes it is, sometimes it isn't. And on weight management interventions, etc. I'm the responsible commissioner for a chunk of those, and we're proud to do that, and we'll continue to do that. It does make a difference for some, but it probably isn't going to shift the dial of population. But again, like smoking cessation, you've just got to keep going in that space. It's just the hard, dogged work of prevention over a long period of time. However, just on the sort of the population impact of weight management interventions, I did once calculate this in a sort of, it was a bit of a back of a fag packet way, but at the current level of investment and the current level of effectiveness of those interventions, that was its average. It's kind of about average, and so some places will have much better outcomes than others. That's just the law of averages. It'd take 250 years to solve obesity by that stretch. And as one of my staff then said at the time, kind of like emptying an ocean with a teaspoon, which is true. But that's the difference between population level perspectives and individual level perspectives, because at individual level perspectives, those kinds of services make an enormous difference for some. So let's be clear on that. And then on GLP-1s, do make a difference, significant difference for some. For a period, we don't know what happens in the long period, and there's lots of worries about side effect profiles. There's lots of worries about people having significant side effects and coming off them. They work for as long as you take them. They're kind of like statins. They work for as long as you take them. And of note, I'm increasingly worried about things like pancreatitis, because I'm looking at the admission rate for acute pancreatitis is going up pretty steeply. I wonder why that might be happening. But they will make a difference for some. And we can all see stories of folk, and I know folk who are on them have lost tons of weight. Fantastic. Do we want to get into the business of medicating 60% of the population? Not sure. And at the current cost, we simply can't afford to medicate 60% of the population. So I'm not convinced mass prescription of GLP-1s is the answer that everyone thinks it is. I'm happy to be proven wrong.
Yeah, that's interesting, and it's sort of it's a multiple. I mean, because this is a podcast around health coaching, I want to circle back to the agency factor, because I suppose from my perspective, we're often talking about kind of the very baseline of health coaching is building people's agency across a whole load of things. So do
Yeah.
they have a sense of self-worth, self-control
Yeah.
for themselves, but then perhaps also I know some people have been writing about whether agency then can play into the public policy arena where sort of in democratic places, people talking about wanting stuff more vocally and behaving in a certain way will influence the policymakers. So I am interested in what you think of that kind of approach to try and build people's agency generally, whether that's for obesity, smoking, the environment, just how we operate with each other through social care. Where do you think that sits in the whole picture then?
All for it. It's a massively important thing. That's one of the things. Again, you and I may use slightly different language to describe the same thing. But when I talk about community development, that's exactly the purpose of community development: is to shift power from state and institution to individuals and communities. Easy to say, it's hard to do for a million and one reasons. I know full well we under-resource a whole bunch of that stuff. And I know full well that we have to get the environment and the context in which people live right to enable some of that agency. And that's a policy versus individual thing again. But it's a fundamental part of my view and thinking and practice, and others can judge how well we actually do that. But agency matters. It matters enormously. It's one of the fundamental tenets of civil life, and one of the fundamental tenets of democracy is people's ability to affect social change. That's called democracy. That's broadly a good thing. So you can and will and should apply agency in a health coaching context, but it equally applies in lots and lots of other contexts as well. And so, and the foundation building blocks are probably the same. So it matters, and it matters enormously. It also matters to make sure the context in which people live their lives is as empowering as our efforts to try and help individuals.
Yeah, no, well, thanks. It's nice to hear you say that, and I like the way you balance the two up. And so I'm going to circle back to prevention as well, because you talked about how hard it is to recognise when prevention's had an impact, because when things don't happen, no one notices it, whereas bad things happen, we immediately cluster around it. But how are we going to, there's this big articulation at a government level, isn't there, to move from reactive care to preventative care? It's one of the big three shifts.
Yep.
I know it's something you've worked on all your career. How are we going to go? How are we actually going to get upstream towards prevention?
Well, one, we are. When someone says, "Oh, there's nothing going on in topic area X or policy," there's always something going on. It's just that person doesn't know about that stuff.
Right.
So I once had a very important, I won't name that person, but a very important and influential clinician say to me, there's nothing going on about tobacco. After I'd picked my jaw up from the floor, I educated that person. The one says, "Oh, I didn't know about any of that," was the response. So often there is a whole bunch of stuff around prevention going on. There's a job of kind of accelerating it. And of course, we all want to invest more in prevention. Usually, the urgency and the immediacy of the acute in your face right now drowns out bandwidth and drowns out resources as well. Let me be clear on that one. That's just life. I saw that to my cost in the pandemic, where I basically stopped doing anything that wasn't managing a COVID pandemic. And a whole bunch of stuff that is my day job, that is prevention, stop. So even I get the immediate versus the long-term important conundrum. And you see this play out in health, but you also see it play out in, say, crime and criminal justice. Well, the prisons are full because we haven't attended as well as we might wanted to of the long-term determinants of crime and criminal behaviour: hope, poverty, good housing, good employment. So, well, guess what? If we don't get that right, prisons get full. And you can draw the logic model between the two things fairly readily. So it applies in health, it applies in lots and lots of other spaces as well. So that will always be a thing. But when I say we're going to shift from the treatment to prevention, or cure to prevention, I have said there's plenty of prevention going on. You just need to know about it, and it's kind of long term and very slowly shift the dial. We can't suddenly turn off treatment. That would be wrong. Imagine if in the car accident the ambulance didn't turn up because they've invested all that money in those public health people. Well, there'd be an outcry. Understandably, I get that. So long term, there's a bit of doggedly doing what folk do over a long period of time, and I'll pick on cardiovascular disease here. So I forget my exact numbers now, but somewhere around 1,000 people have a stroke, 1,000 people have a heart attack in any given year in Sheffield. That massively impactful on people's lives. That number has come down and down and down and down over the decades. For a bunch of reasons. And, I don't think we're quite in that space now, but I vividly remember conversations about closing cardiology wards because cardiovascular mortality, cardiovascular morbidity was coming down. So that happened largely because of access to good quality treatments. Statins, as a secondary prevention, fundamentally shifted that, massively speaking, and long-term approaches to tobacco. Smoking prevalence. Both of those things had a massive downward push on cardiovascular mortality, morbidity. That's prevention in action over a long period of time. Vaccination. We've not quite, but nearly eliminated some things that we used to have enormous outbreaks of over a long period, in the dim and distant history. There are plenty of things that we still worry about around vaccination, but vaccines are probably second only to clean water in terms of the impact public health wise. We've got a well-trod system for delivering vaccination, largely but not exclusively through primary care. It largely works well. There are some things I think we need to attend to in that space, but it largely works pretty well. So that's prevention. But we can't suddenly turn off treatment to shift more into prevention because I'll always fail to some extent. So it's a sort of a balancing of the two. The only other thing I say is one of the reasons this is a healthcare specific thing. One of the reasons why the hospitalization rates go up and up and up is that despite the long-term narrative of shifting from acute to community is currently called hospital to community. Prior to that, it was called the left shift. Prior to that, it was called something else. And prior to that, it was called something else. That's been a long-term policy objective for the UK and pretty much every country in the world for as long as either of us two can remember. But we've done the opposite. The investment has gone down in primary community care. So we want to get into prevention in a macro context. People say, what's the answer, Greg? It's invest in primary community care. Because it's primary community care where you manage long-term conditions that largely turn into one long-term condition turns into 2 and 3 and a multimorbidity of the people have more than one thing wrong with them at any given time. Most of that is preventable, and most of the hard work in that space in the healthcare context is done in primary community care. So kind of investing in primary community care in a macro sense is prevention.
Yeah, no, and we could have another whole podcast about how we manage to shift that dial, but there's a couple of other places I wanted to go with you, Greg, and you can choose whichever you like, really. I'm interested in sort of like how you go beyond the health in terms of, the wider determinants of health. And in particular, we've got quite interested in workplaces and the role that kind of the employment sector can play in building health. And I know you think about those wider determinants of health a lot, no policy without health policy. But then also there's been a rise of lifestyle medicine within healthcare itself as well. And I'm interested whether you want to go on either of those two, whether you think lifestyle medicine is again sort of perhaps barking up the wrong tree, or is it something that's really useful, from where you sit. So where would you like to go on either of those two?
Well, I'll go on both if you want.
I thought you might do. Great.
So workplace health. Firstly, work matters to health. Employment, good quality employment matters to health. Bad quality or no employment also matters to health. So kind of, basic employment policy, basic economic policy is arguably the most important determinant of health. But more specifically within that, work matters to health, gives a sense of purpose, gives income with which you can buy stuff, and buying stuff kind of matters. Gives it gives you ability to afford to pay rent or pay mortgage, or so the income from work matters. The sense of purpose that comes from work matters, but equally we can get it wrong on the other side of the fence by bad quality work or no work. So work matters is clearly matters to UK PLC at the moment. There was, I'll back and do some of these references for show notes if you want. There was the DWP in 2024, maybe 5, published their estimate of the cost of, illness in working age people to UK PLC. It was £250 billion. That's a lot. I don't know how many noughts there are after £250 billion, but a lot of noughts. The vast majority of which was benefit system cost, and lost productivity. The relatively small sum of money was NHS cost, benefit cost and lost productivity. That made the Treasury sit up very, very, very straight in their chest. That's a big number by anyone's stretch of the imagination. And ditto, there was a Office of Budget Responsibility report, I think it was September 2024, long-term fiscal risks for the UK, looking at the clues in the title of long-term fiscal risks. The costs and consequences of climate change were very, very, very sobering, as were the costs and consequences of long-term trends in population health. Treasury read OBR stuff, Treasury Commission OBR stuff. So it matters in that context to UK PLC. Led to fairly significant investment from Treasury on what became known as accelerators and trailblazers, and there's 2 versions, one of which is an NHS-owned entity, one of which is a South Yorkshire Medical Combined Authority-owned entity. We brought together in the same governance, but basically systematic delivery of health care and other interventions to enable people who are close to but not in the labour market to be well enough to work, to get people well. And get people able to work and to get them back in the labour market, because one is good for the economy, 2 is good for individuals. That's a health intervention. It's also an economic intervention for 1,000,001 reasons, but it's certainly a health intervention. And Sheffield and South Yorkshire are doing quite well in that respect. So work sort of matters in that context. And last thought on the work and health agenda, there's a sort of there's an approach by many employers that the answer is an employee assistance programme, bike sheds to encourage people to cycle to work, and a bowl of bananas in the staff canteen. Sorted. Healthy working environment sorted. But if we don't sort out things like toxic bullying, unsustainable workloads, well, those things are causing mental illnesses. So there's a sort of you need to be in that space as well.
Well, we're definitely interested in that space. And I think, the skill set of health coaching within that, which tends to be a bit more upstream in terms of keeping people well, keeping them developing habits that keep them well, whether they're health habits or workplace patterns of behaviour, bosses to juniors, peers to peers.
Yeah, agree.
So I think there's the scope there. So the lifestyle bit, do you want to say anything about lifestyle medicine and how you see that playing its part in the picture?
So I'm not terribly cited on the sort of how the field has developed over the years. I think it's broadly a good thing. I think it's a sort of a systemic and considered effort to try and demedicalise, where appropriate, the delivery of healthcare, which is an entirely a good thing, because there are plenty of things that absolutely require a medical and medicalised model approach, but there are plenty, as you and I both know, that don't. So I think lifestyle, the thing that's become called lifestyle medicine is a fairly systemic effort to try and address a lot of that overdiagnosis, overtreatment, which in itself causes harm. And we know it's hard to document that harm, but we know it's there. The thing I see most visibly in the lifestyle medicine pursuit is there are 2 things. One is the overdiagnosis, overtreatment agenda, and there's a fairly healthy body of people that are pushing quite hard in some of that. Of note, set against that is the sort of medtech industry that will happily flog us with as many pharmaceuticals and medical devices as we want, and they got better PR than those on the opposite side of that.
David and Goliath again.
That's a thing. David won the David and Goliath battle.
Oh, he did, exactly.
So he did
David won
with a few carefully aimed shots. That's a thing. thing. And then the second space I see the lifestyle medicine advocates in is the whole exercise as medicine thing. Wide open goal, go for it, because I think we grossly underuse exercise as a modality of treating people's illnesses, but also obviously importantly preventing people's illnesses. And healthcare is a high volume pursuit where healthcare professionals see very, very, very high volumes of people. Even marginal shifts in that volume of people can achieve a not insignificant goal in terms of improving the health of the population. So, and I see plenty of progress in that space. I'd always want to see more.
Yeah, that's great. Well, we've both been involved in the Move More Sheffield programme for many years, haven't we? And well, maybe that's a clue for you for your last question there. Then is the one thing people can do for themselves and the city to advocate for more physical activity?
Yeah, go on. Well, it'd be a nice, easy thing for me to say.
It'd be nice. Well, I don't want to let you off the hook. What would you say? What would be your final rounding point then of what people could do?
On physical activity and the Move More strategy per se, I think we're now on our third iteration of the Move More strategy. I think we are. But broadly, we've taken a sort of a whole city, whole system, multiple systems all interacting together. Speak to places, environments, parks and green space, leisure facilities, healthcare, all of that in a mix all at once. And the proof is in the pudding. Sheffield does quite well. Sheffield is quite a sweaty city, all things considered. I think to continue my sporting analogy, I think we're somewhere at the bottom end of the Premiership in terms of how we rank. Given our socio-demographic profile, that's no mean feat. And again, that hasn't happened by magic. It's happened because a lot of people have worked very, very, very hard on it over a long period of time. We can do better.
Maybe better than our football teams.
I don't follow
maybe
football.
Better than our professional football teams.
I cycle. I'm a moderate cyclist. We can do better. So let's get to the top of the Premiership.
Yeah.
But we do okay in that city, and that's testament to the broad strategy that we've adopted and the way in which we've enacted over many years. Yeah. So, the one thing, physical activity does matter enormously. I might duck the question because I suppose the big idea, people ask me frequently about what's the one big thing or the three big things. And I don't know. I think the big idea is that there isn't a single big idea. It's the aggregate of a whole bunch of ideas that makes the difference, and doing that doggedly. Can I tell a story on what we're doing with regards to the main risks, to lifestyle risks? And I loathe the term lifestyle for a bunch of reasons, but the main lifestyle risks to health: tobacco, physical activity, food, alcohol. I can. In some of those spaces, we're doing really well, in some less well. Can I tell a story on what the city's doing around the illnesses that those things cause or lead to the increased risk of cardiovascular disease, cancer, etc.? Yeah, broadly. And again, some of those things we do well, some of those things we do less well. Can I go upstream and tell a story about what folk call the determinants of health, but what I will call transport policy, poverty, income maximization policy? Yes, again, but I'm loath to pick the one thing because it's kind of like picking your favorite children. It's a very, very, very dangerous pastime.
Fair enough. I'll let you off on that one,
right,
Greg. And I think maybe that's a good point to finish it. Actually, there's a little bit of everything, and actually, and of course, a key principle for health coaching is base it around what matters most to you. So maybe it's choose the thing that you enjoy the most and you've got most energy for, and start there, and know it has some effect. Well, Greg, the time has flown. Thank you so much for your time, and hopefully that's given people to think about the where your personal agency matters, the individual bit, but perhaps it's been slightly overplayed, and we should be pressurizing alongside that for system approaches. But ultimately, it's going to be a mixture of both, and we're very grateful for you leading us as a city and a country, really, from a public health perspective on this, Greg. So thanks so much for all your conversation today and your efforts globally.
It's a pleasure. It's been fun. I haven't quite got to global yet. I don't think I ever will. But
and the global sense, I mean, you'll get there, Greg. I'm sure, no doubt, you'll be influencing the Donald at some point.
I'm not sure about
Thanks
that.
so much,
anyway,
Greg.
It's fun. Thank you.
Cheers.